Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arawa, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 301 of our pharmacotherapy series, which majors in acute coronary syndrome. The first question is related to patient PhD in the previous two parts of this pharmacotherapy series. Despite sublingual nitroglycerin, PhD continues to have chest discomfort. Would he benefit from IV nitroglycerin? Because PhD is exhibiting refractory ischemic discomfort despite receiving sublingual and topical nitrates, symptomatic management with IV nitroglycerin is indicated. Nitroglycerin lowers the left ventricular filling pressure and systemic vascular resistance, thereby reducing myocardial oxygen consumption and myocardial ischemia. At lower doses, that is below 50 micrograms per minute, IV nitroglycerin preferentially dilates the venous capacitance vessels, which leads to a decrease in left ventricular filling pressure. For patients who have signs of pulmonary congestion, IV nitroglycerin is of particular value. The next question reads, how should IV nitroglycerin be administered to PhD? How should it be monitored? A continuous infusion of nitroglycerin is delivered in a controlled manner, starting with 5 to 10 micrograms per minute, which is then increased by an additional 5 to 10 micrograms per minute every 5 to 10 minutes if needed. Many cardiologists routinely give patients an infusion of nitroglycerin for the first 24 to 48 hours after an acute myocardial infarction. Increasing doses may be required during this period to maintain the desired hemodynamic effect owing to tolerance that occurs from prolonged nitrate exposure. However, if more than 200 micrograms per minute is needed to achieve the desired response, another vasodilator may be needed. Nitroglycerin is typically administered in combination with fibrinolytic agents in patients who require relief from myocardial ischemia. Patients with an inferior or right ventricular infarction often develop hypotension, mean BP below 80 mm of mercury, when given nitroglycerin. PhD's BP should be monitored closely during this infusion. After starting nitroglycerin, we would expect to see his BP decline. The pulse rate may or may not increase. The nitroglycerin dose should be titrated to relieve pain while avoiding symptomatic hypotension. In patients with evidence of heart failure, nitroglycerin can reduce left ventricular filling pressure preload, as well as improve orthopnea and pulmonary congestion. However, excessive doses of IV nitroglycerin can reduce left ventricular filling pressure to excess, and potentially decrease cardiac output. The systolic BP should be maintained to at least 90 mm of mercury. Once PhD's chest pain is controlled, he may be transitioned to either an oral agent or his transdermal delivery system increased. With either choice, a nitrate-free interval should be maintained. The next question reads, JWO is a 65-year-old man who presents to the emergency department with chest tightness and shortness of breath. He gives a history of similar symptoms the previous day that lasted 20 minutes. He was given aspirin 325 mg, intranasal oxygen, oral metoprolol tartrate, and started on an IV nitroglycerin infusion, which was increased to 80 micrograms per minute. At that time, his BP was 130 systolic 60 diastolic, and his heart rate was 88 beats per minute. His ECG revealed ST segment depression in the anterior leads. His shortness of breath was relieved, but he still complained of chest tightness. His past medical history includes hypertension, for which he takes hydrochlorothiazide 25 mg daily. His mother died of a heart attack at age 62. He has smoked a pack of cigarettes per day for the past 30 years. Laboratory values include the following: sodium of 135 milliequivalents per liter, potassium of 4.0 milliequivalents per liter, chloride of 100 milliequivalents per liter, bicarbonate of 20 milliequivalents per liter, BUN of 15 mg per deciliter, serum creatinine of 1.1 mg per deciliter, glucose of 100 mg per deciliter, magnesium of 2 milliequivalents per liter, Kmb fraction of 1%. The normal range is 0% to 5%. Troponin I ultra of 0.05 nanograms per milliliter. The normal value is less than 0.02 nanograms per milliliter. Hemoglobin of 14 grams per deciliter. Hematocrit of 44%. Platelet count of 288 times 10 power 3 per millimeter cubed. Based on his symptoms and ECG, the diagnosis is presumed unstable angina. Should JWO receive an invasive or ischemia-guided strategy for management of his NSTEMI? Although JWO has negative biomarkers after 24 hours from his first episode of chest pain suggesting unstable angina, the presence of new ST segment depression may prompt the clinician to choose an early invasive approach within 24 hours. If, however, the patient is not at high or intermediate risk, then the invasive approach may be delayed and performed within 25 to 72 hours. A TIMI score would also be helpful to risk stratify the patient. JWO has a score of 4, indicating a 19.9% risk at 14 days of all-cause mortality, new or recurrent myocardial infarction, or severe recurrent ischemia requiring urgent revascularization. When risk stratifying, scores of 0 to 2, 3 to 4, and 5 to 7 represent low, moderate, and high risk for death or repeat myocardial infarction at 14 days. So, based on his TIMI risk score, he is moderate risk. As an alternative, calculating a GRACE score would indicate 137 points, representing an 11% risk of in-hospital death or myocardial infarction and a 19% risk at 6 months. An ischemia-guided strategy might be selected based on patient or clinician preference in the absence of high-risk features such as elevated biomarkers. In this approach, pharmacotherapy would be initiated followed by a non-invasive stress evaluation. If JWO were to have elevated cardiac biomarkers during his presentation, his diagnosis would be NSTEMI and an early invasive within 24 hours approach may be preferred. If during his hospitalization, JWO were to experience any recurrent ischemia, arrhythmias, or signs and symptoms of heart failure, he would proceed directly to angiography and undergo possible percutaneous coronary intervention. The next question reads, what anticoagulant regimen should JWO receive? The ACC/AHA guidelines recommend beginning anticoagulant therapy for all patients without contraindications with NSTEMI as soon as possible. The guidelines recommend one of 4 agents: unfractionated heparin, enoxaparin, fondaparinux, or bivalirudine, approved only for patients managed according to an invasive strategy. In NSTEMI, unfractionated heparin has been associated with lower rates of death or myocardial infarction than aspirin alone. Despite its limitations, unfractionated heparin is preferred if the patient is to undergo CABG because of its rapid clearance. For an invasive strategy, the guidelines give a higher level of evidence for enoxaparin but do warn about an increase in bleeding. When choosing an anticoagulant, renal function, bleeding risk, and concomitant therapy should be considered. Data supporting low molecular weight heparins in this setting come from several studies. In the efficacy and safety of subcutaneous enoxaparin, abbreviated as ESSENCE study, enoxaparin, dosed at 1 mg per kilogram subcutaneously twice daily, was compared with unfractionated heparin, 5,000 units IV bolus followed by continued infusion titrated to an activated partial thromboplastin time of 55 to 86 seconds. The composite outcome of death, myocardial infarction, or recurrent angina at 14 days was reduced by 20% in the enoxaparin group. This benefit was maintained for 1 year. In the superior yield of the new strategy of enoxaparin, revascularization and glycoprotein 2b/3a inhibitors, abbreviated as Synergy trial, 9,978 high-risk NSTEMI patients were randomized to enoxaparin dosed at 1 mg per kilogram subcutaneously twice daily, or weight-based unfractionated heparin dosed at 60 units per kilogram bolus followed by 12 units per kilogram per hour adjusted to an activated partial thromboplastin time 1.5 to 2 times control, before undergoing an early invasive strategy. Enoxaparin was found to be as efficacious as unfractionated heparin in reducing 30-day all-cause mortality or non-fatal myocardial infarction but was associated with a significant risk of major bleeding, with a p-value equal to 0.008. Bleeding was especially problematic in those patients who crossed over from one treatment to the other during the trial. In the TIMI 11B trial, enoxaparin 30 mg IV bolus followed by 1 mg per kilogram subcutaneously twice daily for 8 days compared with unfractionated heparin dosed at 70 units per kilogram bolus followed by 15 units per kilogram per hour for 3 to 8 days, reduced the composite endpoint of death, myocardial infarction, or need for urgent revascularization. The benefit of enoxaparin is greatest for high-risk subgroups such as those with ST segment changes, elevated troponins, and a high TIMI risk score. Finally, enoxaparin has been compared with fondaparinux. In the OASIS-5 trial, NSTEMI patients were randomized to fondaparinux, dosed at 2.5 mg subcutaneously daily, or enoxaparin, dosed at 1 mg per kilogram subcutaneously twice daily, for a mean of 6 days and evaluated at 9 days for the primary endpoint of death, myocardial infarction, or refractory ischemia. There was no difference between groups for the primary endpoint. However, compared with enoxaparin, fondaparinux had a significantly lower incidence of major bleeding at 9 days with a p-value less than 0.001 and a greater reduction in mortality at 30 days with a p-value equal to 0.05. Based on these data, the guidelines give preference to fondaparinux compared with other anticoagulants for patients who are at an increased risk of bleeding and being treated with an ischemia-guided, conservative medical management strategy. If fondaparinux is used for a patient undergoing percutaneous coronary intervention, an additional anticoagulant with factor IIa activity such as unfractionated heparin is needed. Bivalirudine is given a Class 1 recommendation in the guidelines. In the acute catheterization and urgent intervention triage strategy abbreviated as Acuity trial, patients with NSTEMI managed with an early invasive strategy were randomly assigned to receive either unfractionated heparin or enoxaparin plus a glycoprotein 2b/3a inhibitor, bivalirudine plus a glycoprotein 2b/3a inhibitor, or bivalirudine alone. No differences in the primary endpoint, composite of death, myocardial infarction, unplanned revascularization for ischemia, and major bleeding at 30 days, were observed between the group receiving unfractionated heparin plus a glycoprotein 2b/3a inhibitor, and the group receiving bivalirudine plus a glycoprotein 2b/3a inhibitor. However, compared with those receiving unfractionated heparin plus a glycoprotein 2b/3a inhibitor, the 30-day composite of ischemia or major bleeding was significantly lower for those receiving bivalirudine alone. This difference was attributed to reduced major bleeding with bivalirudine. The unfractionated heparin versus bivalirudine in primary percutaneous coronary intervention abbreviated as HEAT-PPCI trial was a head-to-head comparison of bivalirudine versus unfractionated heparin. Patients who underwent emergent percutaneous coronary intervention were randomly assigned to receive either unfractionated heparin or bivalirudine. At 28 days, the primary efficacy outcome of equal to or more than one major adverse cardiac events was significantly lower in the unfractionated heparin group. When the individual components were evaluated, there was no difference in all-cause mortality or cerebrovascular accident. The driving factors favoring heparin were new myocardial infarction or reinfarction and additional unplanned target lesion revascularization. The majority of these cases were related to stent thrombosis in the bivalirudine group, 0.9% versus 3.4%, with a p-value equal to 0.001. Major and minor bleeding events did not differ between the two groups. Because JWO is receiving an invasive strategy for his NSTEMI and he has adequate renal function, enoxaparin, unfractionated heparin, or bivalirudine could be initiated and continued until the end of percutaneous coronary intervention. The next question reads, what oral antithrombotic medications should be considered for JWO? For both an ischemia-guided and invasive strategy, aspirin along with AP2Y12 antagonist, loading with maintenance dose, should be added as soon as possible to anticoagulant therapy unless the patient is to proceed to CABG. For an invasive strategy, prasugrel or ticagrelor can be considered in lieu of clopidogrel. The 2014 ACC/AHA guidelines recommend ticagrelor as the preferred agent, which is a Class 2A recommendation. Prasugrel should only be used in patients undergoing percutaneous coronary intervention as long as they are not at high risk of bleeding complications. The use of clopidogrel in NSTEMI was evaluated in two studies. In the clopidogrel in unstable angina to prevent recurrent ischemic events abbreviated as CURE trial, patients with NSTEMI were randomized to placebo plus aspirin, dosed at 75 to 325 mg, or clopidogrel, dosed at 300 mg, immediately followed by 75 mg daily, plus aspirin. The composite of cardiovascular death, myocardial infarction, or stroke was significantly reduced with clopidogrel. However, compared with placebo, an increase in major and minor bleeding was seen. On the basis of these data, clopidogrel with aspirin should be administered immediately on admission and continued ideally for 1 year in patients with acute coronary syndrome. The percutaneous coronary intervention clopidogrel as adjunctive reperfusion therapy, abbreviated as PCI Clarity study, was a planned subanalysis N equals 1863 of the Clarity TIMI 28 study that evaluated the effects of pretreatment with aspirin plus clopidogrel, compared with aspirin plus placebo, in patients undergoing percutaneous coronary intervention with coronary artery stenting. Compared with placebo, pretreatment with clopidogrel significantly reduced the incidence of cardiovascular death, myocardial infarction, or stroke, as well as recurrent myocardial infarction or stroke before percutaneous coronary intervention with no significant excess in TIMI major or minor bleeding. The next question reads, what loading dose should he receive and when should he receive it? What about his maintenance dose? A loading dose of 600 mg of clopidogrel in patients undergoing percutaneous coronary intervention achieves greater platelet inhibition with fewer low responders and decreases the incidence of major cardiac events compared with a loading dose of 300 mg. A 300 mg clopidogrel loading dose provides adequate antiplatelet activity in 6 hours, whereas a 600 mg clopidogrel loading dose provides antiplatelet activity in 2 hours. Even after a loading dose, clopidogrel requires several hours to be metabolized to its active metabolite. The current guidelines prefer 600 mg because of a greater, more rapid, and more consistent degree of platelet inhibition. Patients undergoing percutaneous coronary intervention who have previously received a loading dose of 300 mg of clopidogrel and are on a 75 mg daily maintenance dose should receive another 300 mg loading dose. Data do not exist on additional loading doses for patients currently receiving maintenance doses of prasugrel or ticagrelor. Prasugrel has been evaluated in patients with acute coronary syndrome undergoing percutaneous coronary intervention. In the therapeutic outcomes by optimizing platelet inhibition with prasugrel thrombolysis in myocardial infarction, abbreviated as Triton TIMI 38 study, patients with moderate to high-risk acute coronary syndrome, 26% of whom had STEMI, were randomized to prasugrel 60 mg loading dose followed by 10 mg daily, or clopidogrel 300 mg loading dose followed by 75 mg daily. All patients received aspirin 75 to 162 mg daily. The primary outcome of death from cardiovascular causes, non-fatal myocardial infarction, or non-fatal stroke occurred in 9.9% of patients receiving prasugrel and in 12.1% of patients taking clopidogrel, with a p-value less than 0.001. However, prasugrel was associated with a significant increase in TIMI major, fatal, and life-threatening bleeding. A post-hoc analysis found 3 subgroups that did not benefit from prasugrel: patients with a history of stroke or transient ischemic attack, age of 75 years or older, or body weight less than 60 kilograms. Patients with at least one of these risk factors exhibited a higher rate of bleeding. The Food and Drug Administration (FDA) recommends a 5 mg rather than 10 mg maintenance dose be considered for those patients weighing less than 60 kg, even though this dose has not been studied. In the study of platelet inhibition and patient outcomes, abbreviated as PLATO trial, patients with acute coronary syndrome, with or without ST segment elevation were randomized to receive ticagrelor 180 mg loading dose, 90 mg twice daily thereafter, or clopidogrel 300 to 600 mg loading dose, then 75 mg daily. Compared to clopidogrel, ticagrelor demonstrated a 16% reduced rate of mortality from myocardial infarction, vascular causes, or stroke, with a p-value less than 0.001, without an increase in the rate of major bleeding but an increased rate in CABG-related bleeding, with a p-value equal to 0.03. However, the lowest one-year rates of cardiovascular death, myocardial infarction, or stroke were noted in patients with acute coronary syndrome treated with ticagrelor and maintenance low-dose aspirin equal to or less than 100 mg per day, whereas the highest rates occurred in those treated with ticagrelor and high-dose aspirin, more than 300 mg per day. Based on these data, the maintenance dose of aspirin should not exceed 100 mg per day. When compared with clopidogrel, prasugrel and ticagrelor are more potent, exhibit a lower incidence of stent thrombosis, have fewer drug-drug interactions, and lack variable response based on pharmacogenomics. However, many providers have been concerned with the higher risk of bleeding. In the case of JWO, clopidogrel, prasugrel, or ticagrelor could be added, as he does not have a contraindication to any of these drugs. Ticagrelor may be preferred as long as cost is not a concern for the patient. After percutaneous coronary intervention with coronary stent deployment with either a drug-eluting or bare metal stent, clopidogrel 75 mg, prasugrel 5 to 10 mg, or ticagrelor 90 mg twice daily should be administered for at least 12 months. It is important to highlight that clopidogrel and ticagrelor should be discontinued for 5 days and prasugrel for 7 days prior to surgery. As a rapid onset of action is needed, JWO should receive a loading dose of 600 mg of clopidogrel as soon as possible, followed by 75 mg daily for at least 12 months. If prasugrel is chosen, a loading dose of 60 mg would be given followed by 10 mg daily as long as the patient is above 60 kg. For ticagrelor, a loading dose of 180 mg is recommended following by 90 mg twice daily. Aspirin 81 mg daily should be continued indefinitely. The next question reads, should a glycoprotein 2b/3a inhibitor be added? If so, which one? In patients with NSTEMI, the glycoprotein 2b/3a inhibitors are of benefit for patients considered high risk, those undergoing percutaneous coronary intervention, or both. Analysis of glycoprotein 2b/3a studies suggest that those patients who obtain the greatest advantage from these agents are those who have elevated troponins, diabetes mellitus, ST segment changes, or a TIMI risk score of 4 or higher at presentation. The guidelines recommend that for patients with NSTEMI who will be treated initially according to an invasive strategy, either a glycoprotein 2b/3a inhibitor or a P2Y12 inhibitor, that is clopidogrel or ticagrelor, should be added to aspirin and anticoagulant therapy before diagnostic angiography is performed. When used to treat patients medically, the glycoprotein 2b/3a inhibitors tirofiban or eptifibatide are generally given for 18 to 72 hours. Abciximab should be used only with percutaneous coronary intervention. The GUSTO-4 ACS trial enrolled patients with NSTEMI in whom early, less than 48 hours, revascularization was not intended. All patients received aspirin and either unfractionated heparin or low molecular weight heparin. They were randomized to placebo, abciximab bolus and 24-hour infusion, or abciximab bolus and 48-hour infusion. At 30 days, death or myocardial infarction occurred in 8.0% of patients receiving placebo, 8.2% of patients receiving 24-hour abciximab, and 9.1% of patients receiving 48-hour abciximab, with no significant difference. At 48 hours, death occurred in 0.3%, 0.7%, and 0.9% of patients in these groups, respectively, placebo versus abciximab at 48 hours with a p-value equal to 0.008. Based on these findings and those of other studies, abciximab is indicated only if angiography will not be appreciably delayed and percutaneous coronary intervention is likely to be performed, otherwise, IV eptifibatide or tirofiban is preferred. The guidelines recommend that in the setting of dual antiplatelet therapy used with unfractionated heparin, the adjunctive use of a glycoprotein 2b/3a inhibitor administered at the time of percutaneous coronary intervention cannot be recommended as routine therapy. However, a glycoprotein 2b/3a inhibitor may be beneficial in those with a large thrombus burden or who have not received adequate P2Y12 antagonist loading. JWO has a TIMI risk score of 4, therefore, the addition of eptifibatide or tirofiban is a reasonable choice if a large thrombus burden is demonstrated on angiography. Administration prior to percutaneous coronary intervention upstream is not indicated unless the administration of a P2Y12 antagonist is delayed until time of percutaneous coronary intervention. Platelets and signs and symptoms of bleeding should be monitored closely. Because JWO is not at high risk for bleeding, dual antiplatelet therapy in addition to unfractionated heparin should be adequate therapy. If a large thrombus burden is demonstrated on angiography, a glycoprotein 2b/3a could be initiated during percutaneous coronary intervention. If JWO had not received an oral P2Y12 inhibitor or a glycoprotein 2b/3a inhibitor, consideration could be given to administering IV cangrelor, a direct-acting P2Y12 platelet inhibitor, prior to percutaneous coronary intervention. Based on the results of the Champion Phoenix trial, cangrelor could be administered as a 30 micrograms per kilogram bolus followed by a 4 micrograms per kilogram per minute IV infusion for at least 2 hours or for the duration of the percutaneous coronary intervention. After discontinuation of the infusion, an oral P2Y12 inhibitor should be administered, that is ticagrelor 180 mg load during or upon immediate discontinuation of infusion, or prasugrel 60 mg or clopidogrel 600 mg upon immediate discontinuation of infusion, followed by aspirin 81 mg daily along with a maintenance dose of the P2Y12 inhibitor. If clopidogrel or prasugrel are administered during the infusion, they will have no antiplatelet effect until the next dose is administered. The next question reads, what if an ischemia-driven strategy was decided for JWO instead, would his antithrombotic therapy change? Let's look at an ischemia-guided strategy. An ischemia-guided strategy avoids early invasive procedures, instead relying on the patient's symptoms to direct the need for intervention. Similarly, JWO would be optimized on anti-ischemic and antithrombotic regimens. At this time, prasugrel and bivalirudine are only indicated in patients undergoing percutaneous coronary intervention. Additionally, the bleeding risk of glycoprotein 2b/3a inhibitors outweighs the benefit in this approach, and therefore these medications should only be used if percutaneous coronary intervention is pursued. If during his hospitalization, the patient were to experience any recurrent ischemia, refractory angina despite medical therapy, or high-risk features e.g., arrhythmias, signs or symptoms of heart failure, hemodynamic instability, or elevated cardiac enzymes, an invasive approach would be pursued. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arawa, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 302.